Welcome to our DeBakey Heart and Vascular Weekly Grand Round series. Just some housekeeping issues. We are broadcasting this live via live stream and YouTube. The recording is always available for viewing. Consider subscribing to our YouTube channel to get notifications. And for those viewers who want to submit a question, text DeBakey to 37607. And you can also submit questions via live stream feed. And also keep tuned for our next conference is Heart of a Woman, end of April 27th. And of course, our own one-day cardiovascular disease prevention symposium on May 4. So it's truly a pleasure to introduce our guest, our speaker here today, Dr. James Januzzi. Doesn't need any introduction. He's the Herter family professor of medicine at Howard Medical School, also director of heart failure and biomarker trial at BAME Institute. Graduated from medical school in New York, and since over 30 years now, a resident of Boston, did his internal medicine residency at Brigham, then fellowship at MGH, and stayed there since 2000. He's, I would say, among the most cited scientists in the world, almost 900 publications, but truly more than the breadth and the depth, it's the impact that really counts. And as physicians, cardiologists, internists, ED, we all use markers, cardiac biomarkers, but his study has really set most the international standards in the use, diagnosis, and treatment, and more so his pioneering work in getting the NT-proBNP as the gold standard marker in heart failure. He is still involved with tremendous amount of clinical trials, and I'm sure anybody going to ACC will see him presenting some of the late-breaking studies. He's also one of the trustees at ACC, and delighted to have him as the deputy editor-chief for JACC, and will be an honor working with him. But of course, my favorite part is that for the last almost 20 years, he's the team physician for the Boston Red Sox baseball team. Of course, the number 2 team after Astros. So again, without further ado, Dr. Januzzi.
Thanks, Dr. Nazir. Good morning, everybody. Really grateful for the opportunity to come and speak with you all today. I view this as a privilege to be able to come and spend time with colleagues, old friends, and talk a little bit about where we've been over the years with respect to cardiac marker testing, where we are now, and where we're going. Although I've spent the majority of my career focused to one degree or another on the use of cardiac markers for evaluation management of patients with cardiovascular disease. What I want to try to do today is really focus, I'll drop a little bit of our own work in there, but focus really on sort of things that you may not know about, where the field is heading. We still have some ambiguities, I would say, but nonetheless, there's a lot of opportunity to advance the field and improve care for our patients. And that was sort of the goal for this talk today. My disclosures are here. I work at the BAME Institute for Clinical Research, and so as a consequence, we do a lot of industry-sponsored research. That's important to keep in mind, although most of it is pharma and devices rather than biomarkers. So very, very importantly, I'm a clinician. Dr. Nazir and I were talking about this, point as we were coming in, our clinical volume, et cetera. I'm one of the heavier volume clinicians at Mass General in the cardiology division, even still, although that's scaled back somewhat over the last few years. But I think it's really critically important, and it has always been in my career, to ground the understanding of what biomarkers are telling us within clinical judgment, because I think that if we approach this problem with a black or white, all or nothing kind of approach with respect to whatever test, calcium scoring, imaging, biomarkers, it will cause more confusion and prevent us from seeing the opportunities for expanding the use of markers, for example. So there are a support to clinical judgment. They do not replace clinical judgment, but importantly, markers can inform things that we can't see at the bedside. We can't measure with strain echo, for example. And so as a consequence, there is a lot of opportunity to learn about our patients and potentially improve their outcomes. So what I'm going to do is I'm going to focus largely on heart failure during this talk. Should come as no surprise. That's largely where I've spent my career with respect to markers as well as clinically. But suffice to say, and Dr. Nazir and I have gotten into discussions on Twitter about this over the years, depending on the disease state, some markers are better than others for that specific disease state. And for heart failure, at least, circulating markers are very, very good for predicting the future risk. So it should come as no surprise that's where I'm going to largely focus. So I'm going to ask you to sort of silently think about how you think about natriuretic peptides on the left and troponins on the right. I mean, into what bin do you put them? And I can tell you that, saying the quiet words out loud, on the left, I see natriuretic peptides and I think, all right, patient's short of breath in the ED. We're going to draw some blood and measure an NT-proBNP. On the right, same patient has chest heaviness. We're going to measure a troponin to seek myocardial infarction. I assure you that in the balance of the slides coming up, I will spend probably 1 or 2 slides total on acute heart failure and no slides on acute myocardial infarction when I talk about these markers. So in other words, what I really want to try to do is broaden the horizon as to what these tests can potentially be used for as a tool to better understand disease states and potentially intervene. So let's start first with the natriuretic peptides. It's a really fascinating story, actually, and it begins actually in the 1960s when Eugene Braunwald, then by the way, that photo in the middle is not Gene, that's actually Adolfo Debalde. They kind of look similarly in some ways. But on the left here is an editorial that Dr. Braunwald wrote speculating the heart as an endocrine organ. And I love this screen grab of the paper from the American Journal of Medicine, from the Green Journal. And what Gene was writing about was the use of circulating substances in the blood to prognosticate heart failure, actually. And he was writing about CRP, actually, which is sort of interesting. And on top of that, he was editorializing about a study that he did. So think about that. Like, this is like, Gene Braunwald was Gene Braunwald even in 1964. He was editorializing on his own study, which I would love to do. I'd love to be able to review and editorialize my own trials. But, as is usually the case, he was absolutely right. Cardiomyocytes are metabolically active. They are active from an endocrine, paracrine, and autocrine fashion and release substances into the blood that regulate different disease states. And that fast forwards us now 20 years later to 1984 when Adolfo Debalde, a really kind gentleman from Argentina who was living at the time in Montreal and subsequently to Ottawa, began to study the response in laboratory animals to the injection of these electron-dense granules identified on electron microscopy from the atria. And what he found was that injecting these substances, this factor, as he referred to it, it induced an intense natriuresis and diuresis, and he referred to this as atrial natriuretic factor, ANF. Well, ANF, of course, subsequently was identified as being a peptide, and the natriuretic peptide family now exists in multiple different forms. Of course, ANP being the first one identified, but the one that you all know probably better is B-type natriuretic peptide, originally identified in brain homogenates, but subsequently identified in many other tissues throughout the heart, largely. It's not really found much elsewhere, but it is a neurotransmitter in the brain, regulating feeding activity. As well, and of course, it's found throughout the entire myocardium. And we'll come back to that because I think that's a really important point when we're starting to think about what else besides, the classical use of natriuretic peptides for the patient that's short of breath sitting in the emergency department. The other members of the natriuretic peptide family, all, as you can see, all have this ring structure which is required for their biological activity. The natriuretic peptides are highly conserved across species. They arose actually from deep water fish to regulate osmolarity of blood and are largely strikingly conserved sequence-wise. So your BNP, ANP is very similar to that in other animal species, which is really pretty striking, actually. Biologically speaking, and it's an important slide to understand, because not everything that we thought we knew was true. Natriuretic peptides are synthesized in response to myocardial stress. Now, I didn't say heart failure, I said myocardial stress. In that setting, a pre-pro peptide is synthesized, loses a signal peptide, and yields this very important pro-peptide, proBNP 108. It's kind of unfortunate, actually. We refer to N-terminal proBNP as proBNP frequently. That's actually, from a nomenclature perspective, incorrect, because there is a proBNP, and I'll tell you why that's important in a second. In a normal non-diseased heart, what then occurs is after synthesis, and unlike ANP, which is stored in granules, as I showed you on that electron micrograph, the Bs are actually synthesized de novo, right? So you don't have any intracellular storage. This all happens after transit from the nucleus to the Golgi apparatus, et cetera. Within the Golgi and soon after, this intracellular proBNP is cleaved by an enzyme called corin, also furin, and there's some peripheral conversion as well after release, and releases these two peptides, right? So this is literally almost a slide from about 2005. This is what we thought was happening at the time, which is, okay, you get one N-terminal proBNP and you get one BNP. And BNP, the business end of the molecule, does all of the biological stuff that we think the heart is releasing natriuretic peptides for. So depending on which peptide we're talking about, the A type and B types bind to the A receptor, natriuretic peptide receptor A. CNP, which is found in vascular endothelium, relatively low quantity, but plays a role in hypertension largely, binds to the B receptor. And then all of them are cleared by the C receptor, C for clearance, which binds and removes. The A's and B's bind to this A receptor to a larger molecular concentration than the C type, and leads to intracellular generation of cyclic GMP. That's the downstream second effector of all of the biological goodness, if you will, of the natriuretic peptides. Vasodilatation, salt and water release, reduction in fibrosis of the myocardium, improvement in lusitropy. So, teleologically, you could understand why the heart would want to release this stuff in the setting of whatever deleterious injury is occurring, whether it's severe hypertension, volume overload, hypertrophic cardiomyopathy, whatever. I mean, there's a very non-specific trigger, that being myocardial stress, right? So then, let's see, why isn't it forwarding? Let's see if I can get this to move forwards. Oh, there we go. Okay, so now we're back. Okay, so now we're back to the processing of natriuretic peptides. So as I said, this is where we were in about 2005. We thought that, there was one of this and one of that. And then, much like, things haven't really changed, right? So people love to argue about calcium scoring, Karam, but, back then people were like, well, BNP is better and NT-proBNP is better. And we thought, okay, it's either this or that. And then we realized that there were things that we didn't realize. Number one is that, in fact, BNP doesn't really circulate as an intact ring like we like to show in our figures. In fact, if you do mass spectroscopy of patients with heart failure, what you can appreciate is that despite the white bars being high concentrations of BNP using the usual assays that we use, in fact, using mass spec in the black bars is the actual concentration of what's circulating. So these degraded fragments of BNP vary from person to person, and you can see in the spectra all the various BNP fragments that exist. Here's the really interesting thing. Each one of these fragments has somewhat of a different biological effect. So some give you more natriuresis, some give you more diuresis. And this has led people like John Burnett at the Mayo Clinic to start thinking about taking pieces of the natriuretic peptide ring and fusing them together to get different designer effects that you can harness. So some may give you more natriuresis for people with volume overload. Some may give you more vasodilatation for people with hypertension. And so that's definitely something in the future that I completely expect you'll be seeing. And this also is very, very relevant, and the reason why I bring this up, to our current state in the heart failure world, which is we use drugs that inhibit probably the most potent degrader, to create a word, of BNP, which is neprilysin, right? So all of you know that we use sacubitril valsartan for reduced EF and for some patients with preserved EF heart failure. And part of what neprilysin inhibition does is it blocks the breakdown. All of these red arrows are where neprilysin assaults the natriuretic peptides. It blocks the breakdown of these various peptides. This is important because there's a lot of, I would say, confusion, misinformation about what this does to the circulating natriuretic peptide concentrations in patients who take drugs like sacubitril valsartan. What has been shown in the Paradigm trial was that there was about a 19% increase in BNP after initiating. But clinical practice has actually argued against the rise in BNP as being all that substantial. And in fact, we just recently published not long ago some data out of a study that we did where we looked at patients initiated on sacubitril valsartan in two studies, PROVE-HF and EVALUATE-HF. And what we found was, in fact, that although the NT-proBNP values, and NT-proBNP is not affected by neprilysin, drop, the BNP values, and we looked at several BNP assays actually, and this is also this is more kind of nerdy lab medicine stuff, but it turns out that all of the different assays for BNP, the antibodies for the assays bind to different places in the BNP ring. So what we found in this analysis was that depending on which BNP assay you use, you actually see variable change in how much rise you get. And that makes some sense. If you think about all those fragments that are circulating, what happens is you get a rise in some fragments more than others when you go on to sacubitril valsartan, and some of the assays are better than others for picking that up. But by and large, what we found was that there was really no decrease but no increase, and that's, I think, reassuring for clinicians who want to measure BNP, not NT-proBNP, in folks treated with sacubitril valsartan. Right? And so, and the other thing is BNP remained highly prognostic in this population. Lastly, about sort of things that we wish we knew back when we were arguing about which peptide was better, it turns out that depending on how sick a patient is with heart failure and how advanced their heart muscle disease is, rather than cleaving and releasing one NT-proBNP and one BNP, more and more and more, what the patients are releasing is this uncleaved 108 amino acid proBNP peptide. So ask yourself this question. Have you ever wondered why a person with worsening heart failure has higher and higher and higher NT-proBNP values, but their EF is only slightly dropping? They may be somewhat volume overloaded, but you're pumping them with diuretic, and all that you're getting is a rise in creatinine. Part of what's going on is the heart is releasing more and more uncleaved peptide, and this uncleaved peptide, which, by the way, is cross-reactive with both assays. So no matter whether you measure BNP or NT-proBNP, because, I know I'm on camera and I shouldn't walk, you've got NT-proBNP here and BNP here, the assays bind to the same peptide. So we were arguing one was better than the other when in fact we were measuring the same thing, which is kind of embarrassing. But more importantly, proBNP 108 doesn't trigger cyclic GMP. It doesn't cause vasodilatation. It doesn't improve lusitropy. It does not reduce fibrosis the way active BNP does. So what's happening is the heart, in a valiant effort to try to get that cyclic GMP stimulation that active BNP gives it, it is making more and more and more to try to raise the proportional amount of free BNP. I bring this up for a couple of reasons. One is it's important to try to understand as clinicians, when you see patients with this rising trend, that what's very likely happening is exactly this phenomenon, but also, very importantly, it's a real avenue towards understanding opportunities for drug development, for therapeutic development for heart failure, to try to understand how we can improve the activation, the splitting of the proBNP molecule into an active BNP format. And if we can't do that, provide it pharmacologically. Now, we failed with natriuretic, which was recombinant BNP, but there are a number of therapeutics coming now that directly stimulate the NPR-A receptor. So remember I showed you the A receptor where ANP and BNP bind. There are a number of trials, I'm involved in a couple of them, where there are therapeutics that mimic the effect of binding to the A receptor through monoclonal antibody stimulation. So for patients with very high concentrations of proBNP 108, this may be a very personalized, direct way to manage their heart failure. Okay, so let's give some background about troponin now, right? So, I realize that some of this stuff is sort of wonky, lab-based, but it's, these are important things to understand since we test these things every single day. Hugo Katos, wonderful guy from Heidelberg. Hugo was working in 1982 at Massachusetts General Hospital in the Warren building. And up on the 14th floor, he worked with Ed Haber, who was the chief of cardiology at the General at the time. And Haber was developing an imaging test for myocarditis. It was a test for anti-myosin antibodies. Jagat, do you remember the anti-myosin scan? Yeah, we used to do that periodically in patients. And Katos said, we're developing antibodies against proteins from the heart. Myosin's not very specific. Are there proteins that are more specific? And Haber said, kid, you're chasing ghosts. It's never going to happen, right? Well, there were a number of proteins isolated from the myocardium that were called troponin. Troponin I, troponin T, troponin C. And the troponins were named based on what they did, right? So troponin I inhibited actomyosin ATPase, troponin T bound to tropomyosin. And as far as Hugo could tell, troponin I, troponin T were pretty darn specific for myocardium. So he actually spent time at MGH working on developing an immunoassay for troponins. And he extended his work after he left. And he is largely credited as being one of the pioneers for the development of troponin as a biomarker for myocardial injury. Now notice, again, I'm very careful how I choose my words. I didn't say heart failure when I said myocardial stress. I also didn't say myocardial infarction when I'm talking about troponins, because myocardial injury is really what they detect. Now, fast forward many years later, Hugo was instrumental as well in this. Many others that we all know were also quite participant in the development of high sensitivity assays for the detection of myocardial injury, as reflected by a rise and/or a fall of cardiac troponin. And the way that high sensitivity assays work, and you've switched to high sensitivity here? Yeah. So the way they work, it's not high science really. The antibodies are just loaded with more immunofluorescent label, and the test takes a bit longer to allow the readout to identify. But you're able, with high sensitivity, to sort of get like an electron microscope-like fidelity for detecting even small changes, whereas with the conventional troponin assay, the resolution for small concentration changes was really inadequate. So when you look at the difference between a high sensitivity versus a conventional, high sensitivity, if I measured a troponin in every one of you in the room, about half to 2/3, depending on the assay. There are some now that go down to the femtogram level, where everyone has a measurable concentration of troponin. But right now, the AACC, says that basically a high sensitivity assay should detect troponin in more than 50% of people without risk factors like hypertension, CKD, diabetes, and it should be able to do so with very good coefficient of variation, which is if I measure it twice, it's within 10% of those two measurements, of each other. The reason why this is important is when we start thinking about where troponin might be useful, beyond, of course, evaluating patients with chest discomfort, which I will not talk about today, is trying to understand just why the heck people in the general population have measurable values, right? Is it normal to have myocardial injury? Is it a normal process to release components of the sarcomere into the bloodstream. When we were developing the universal definition, we had no expectation that we would see this. I mean, I'll just say it right out. We did not think that we were going to see much in the way of myocardial injury, and yet 2/3 of us have circulating troponin, and it's really fascinating. You know, talk to the preventive people about what in normal health what this means. I mean, there's a very interesting sort of literature about, you know, if you're male, if you're over 6 foot like me, you know, you have higher values, you have more muscle, right? More heart muscle, and so it's a direct measure of myocardial mass. But this is where it really, I think, gets interesting, because a lot of what we thought, again, we knew, we were wrong about. Oh shit! Sorry, sorry, I just cursed online. May I have a napkin, please? Could someone bring me up? Thank you. So what we thought we knew was wrong, actually. So even on this slide, I have an incorrect point. So there are 2 pools of troponin in the cardiomyocyte, and this is something that was known for a while on the basis of ultracentrifugation. Thank you so much. I appreciate it. Just don't want to. Thank you. Thank you very much. So the first is that on the basis of ultracentrifugation, we knew that there was troponin in the cytosol of the cardiomyocyte. We had no idea why, right? In retrospect, and now with more studies, what we recognize is there's a normative turnover of sarcomeric protein. And this is probably troponin in transit to the Golgi and to other organelles for degradation, right? But regardless, there's troponin in the cytosol of cardiomyocytes. It's about 3 to 4% of the wet weight of the cardiomyocyte. Of course, most of the troponin is in the contractile apparatus, you know, the sarcomere. So here's the incorrect part of the slide. In the setting of myocardial injury, again, not MI, myocardial injury, 2 things happen. The first is the cytosolic troponin flies out of the cell. You know, as soon as the cell membrane starts to break down. And this is why with high sensitivity assays, you can pick up a delta troponin within an hour, right? So we use a 0-1 protocol at Mass General, which is pretty darn sensitive for identifying changes. After this, you start getting degradation of the contractile apparatus, and you get that delayed, persistent existence. But the thing that's not correct about this is, although myocardial injury is by far the most important trigger for us clinically, it turns out actually that you can release troponin without injuring the cell at all, without killing the cell at all. So if you stress a cardiomyocyte, if you put it under hypoxic conditions, if you expose it to endotoxins, if you stretch it, actually, and believe me, there are people who actually spend time sending these little models up where they put a myocyte between 2 needles and stretch them. What you find is that the cells express a Mayday program, which is they start shedding what are called exosomes, which are these little blebs that come off of the cell membrane. And the cells don't die when they do this. This is thought to be a program of cell-to-cell communication. And there are a number of things within the exosomes that the cells are shedding. And we do not by any means think that the troponin that has been identified in these exosomes, and see this little yellow spot here? That is literally a single troponin molecule that we visualized using electron microscopy. So that's an exosome with 1 troponin molecule in it. We don't think that the troponin in these exosomes is playing a role in signaling, but because it's in the cytosol and because it's being released in these exosomal packets, they're getting into the bloodstream. So some of the circulating troponin that we measure, and what is seen on the right are a bunch of different colored dots that really don't matter too much, but what we've shown is that depending on the disease state, heart failure, chronic kidney disease, normals, the relative proportion of exosomal troponin varies. And so ask yourself, when you're measuring a high sensitivity troponin and you're going to come and yell at the person who brought it to your institution, like I get all the time at Mass General, you're measuring high sensitivity troponin and it's abnormal and the person doesn't have an MI. And you're like, this test stinks. I don't know what it's telling me. You're picking up either injury from non-ischemic processes or you're picking up myocardial stress. We see it all the time in heart failure. The exosomal component in heart failure patients is considerably higher. So a lot of the rise and fall that you see in acute heart failure is probably just like the rise and fall of BNP. It's coming out of the myocardium because of the stress that the heart muscle is under. And this is a tie-in to the potential utility of these tests to identify risk on a clinical level, because there is nothing normal about having abnormal concentrations of these biomarkers. So just like Dr. Desir will talk about the power of 0 for coronary calcium, you never want to have coronary calcium, right? I mean, like even if it's 50, 60, that means you've got something in your coronaries. The same thing goes with biomarkers. If they are above a certain level, it identifies disease, even if no other imaging test tells you there's something abnormal. So the universal definition of heart failure was published 2 years ago now, where what we did was we put together a rubric very similar to among many other categories where you have a preclinical population, the at-risk population. These are people that are at risk for heart failure. I have hypertension, so I have stage A heart failure. And then we talk about a pre-heart failure stage. This is a critically important population that is absolutely enormous in number. These are people that have what we call stage B heart failure or pre-heart failure, who have no signs or symptoms either now or previously, but who have some underlying structural stress, whether it's detectable using imaging or using circulating biomarkers. Because study after study has shown that in these patients, we can identify a clear and present risk for progression to symptomatic stages of heart failure. So stage A, people like us, people like me, I have hypertension. Stage B is really, for me, even though I focused on symptomatic heart failure my whole career, prevention is where it's at. I just tweeted that yesterday. I think if we're ever going to get our arms around the epidemic of heart failure, it's not going to be, much as I'd love to give GDMT to my patients with symptomatic heart failure, that's not the solution. It is not the solution. It's about prevention. So can these patients be identified? We looked at the implications of the universal definition, which was shifted to include abnormalities of high sensitivity troponin or natriuretic peptides. And we asked the question, will that reduce the specificity? In other words, for everyone that comes and sort of knocks my door down and says, this NT-proBNP is abnormal, the patient's fine, it's a false positive. Are there false positives? And the answer is no. I mean, yeah, sure, there are the occasional analytical false positive. But what we found was that by adding, and this is a pooled analysis of ARIC, Framingham, and CHS. What we found was that by adding abnormal biomarkers to the previous definition, so the previous definition was just an abnormal echo, right, structural abnormalities. Now it's abnormal echo plus biomarkers. There was a doubling of the number of individuals with stage B heart failure. So it boosted the number of people that were identified as being possibly at risk. But here's the really interesting thing I thought about this paper. First of all, many more women were identified. So there was a disproportionate shift towards identifying more women as being high risk. And that actually, to some extent, makes sense because for the one person in the room who knows this, natriuretic peptides tend to be slightly higher in women in health. And so an abnormal NT-proBNP, not surprisingly, was more commonly seen in women. In addition, it identified more individuals with social determinants of health. So Hispanic individuals and Black individuals were more likely to be up-classified in risk. So now we've increased the denominator. How about the numerator? What happens in terms of the ability to predict risk? And so here are Kaplan-Meier curves looking at the previous definition and the new definition for transition to symptomatic heart failure. The take-home message is denominator and numerator both expand proportionally. So by adding biomarkers to the ability to predict risk, you increase the number of people that you identify as being likely to proceed on to symptomatic heart failure without reducing the specificity of the finding. Same thing for cardiovascular death. So That's an important observation as we start thinking about what in the heck we're going to do with this, right? We've got a set of biomarkers. We've got 1,001 papers from the Framingham, from Mayo Clinic, other places showing that, yes, indeed, you can identify risk, but how do you operationalize this and in whom? The idea is that using a biomarker-based detection strategy is identifying the earliest molecular signals. I would argue that once a person is shedding natriuretic peptide or troponin, they've already got heart disease, right? It's sort of like saying that somebody with coronary calcium doesn't have coronary disease, clinical coronary disease. They do, they've got it. So I would say it's even too late. Ultimately we'll shift to primordial prevention of heart failure, but at least now we have a tool that is widely available, inexpensive and easily measured to identify these earliest signals. And indeed there are studies showing that once a natriuretic peptide, and the same thing goes for troponin, is abnormal over time, and if you scan these people, left ventricular mass increases. So you're identifying a signal and this is by no means every single patient, of course, but in general, on a population level, you're talking about a signal of heart muscle stress that is likely to progress either to left ventricular hypertrophy or HFpEF. So operationalizing this, leave it to non-cardiologists to show the way. Right? So we in cardiology have argued for years about, biomarkers are so, I don't know what they're for. And even our guidelines actually have it as a 2A, by the way. And it's been there now since 2017 or 17. But the American Diabetes Association looked at the data for cardiac biomarkers in persons with diabetes, and they said, this is absolutely unbelievable. You can take a person with diabetes and measure an NT-proBNP. So for example, we showed in the Canvas trial that if somebody had an NT-pro over 125, they had a hazard ratio of more than 5 for incident heart failure during the 2 years of follow-up after enrollment. And furthermore, in ELIXA, if you measured it serially, a rising trend was even more powerful. So the ADA basically said, all right, enough arguing. The tests work. And so the American Diabetes Association in a recent consensus document recommended at least yearly measurement of a high sensitivity troponin or natriuretic peptide. Now, I'm simplifying a lot of the data behind this. Ambaresh Pandey has done some great work on this in ARIC. But the bottom line is ADA now, both in this consensus as well as in their standards document, recommends yearly evaluation of individuals with diabetes. And as I said, it's been in the guidelines, our guidelines for years, and yet, we've largely dragged our feet. But I think to the extent that the goal is going to ultimately be prevention of heart failure, as we start thinking about evaluating our patients with risk factors, this is an important exercise that we need to be following. I won't go through this whole slide. Tony Biasganis, a dear friend from Barcelona, published a paper endorsed by the European Society where it goes through the individualized approach using a single cutoff, or if you're more inclined, you can use an age-adjusted approach. Because it turns out as we age, we get a little gray hair, we get a little gray hair on our myocardium. It's not unusual as we accumulate abnormalities like diastolic dysfunction that our ambient levels of natriuretic peptide rise over time. And so understanding the thresholds that identify risk depending on age, I think, is important. For people with very high values, more likely than not, they've got stage C heart failure and they just don't know it. They've reduced their activity level such that their symptoms are mitigated. But this is really sort of the future, I would argue, for natriuretic peptides. What about symptomatic heart failure patients? This is another, I think, really important topic because I'm not going to talk about the use in the emergency department, but I will say it's important to remember that when a person has symptomatic heart failure, natriuretic peptides don't tell you just one thing. They tell you myocardial stress. So in the setting of heart failure, acute heart failure, it's all about volume overload, right? And so it's not surprising that, it's useful for diagnosis, but it's not surprising that in acute heart failure, secular trends in natriuretic peptide concentrations are quite useful for judging the adequacy of therapy given during hospitalization. In other words, Getting a baseline and pre-discharge value is actually has quite high fidelity for sorting out individuals that are more likely to have a 6-month event versus those who are not. And very importantly, it's the delta of 30% that we shoot for in our own institution. So when we have somebody admitted with acute heart failure, we get, pile it on. We get a baseline. We do all the things we do, quad therapy for reduced EF, and then at the end of the hospitalization, we'll remeasure to look for that delta because it helps to make decisions about post-discharge care. And that's, sort of the next sort of topic, the bridge from hospital to home. And this is where it really starts getting interesting. So there's a lot of data recently about harnessing the role of cardiac biomarkers for outpatient management of heart failure. These are data from the GUIDED trial looking at patients who at time 0 had their heart failure therapies intensified, and then 90 days later, which is the 0 on the x-axis, their natriuretic peptides were measured. So these are post-treatment NT-proBNP values. And what we were able to show is that people who were able to get under 1,000, an NT-proBNP under 1,000, had a 66% reduction in all-cause mortality and a 74% reduction in the composite of mortality and hospitalization. So these trends over time, everyone started above 1,000. These trends over time are very telling about the likelihood for prognosis. But it gets even more interesting because in GUIDED we measured a whole bucket load of troponin, natriuretic peptides on every patient. So every dot is an NT-proBNP measurement. And what we just recently published, this paper actually was just published in JACC Heart Failure, was that over time people with an event had an upward bend in their NT-proBNP concentrations weeks to months before their event. So again, remember what the heart does when it's failing. It starts releasing more and more natriuretic peptide, more and more proBNP 108, which is detected with this assay. So that's an important observation because it implies that serial measurements in the outpatient setting can prognosticate events. Furthermore, Reza Mohebi in our group has looked at a number of different ways that you can look at concentrations of natriuretic peptide, such as using sort of taking an aggregated stretch of time and integrating the area under the curve, right? So a person who starts out high but then falls immediately and stays low has a low area under the curve. Someone that starts out high and gradually falls has a higher area under the curve. And what Reza showed is that the lower the area under the curve, the faster and more robust reduction you get with treatment, the more reverse cardiac remodeling patients get, and the better their health status. And indeed, the reverse remodeling signal is really a profoundly important part of why serial measurements is so useful. Again, from GUIDED, these are post-treatment changes in NT-proBNP over time, showing that the people with the biggest reductions in NT-pro had the largest rise in ejection fraction and the largest reduction in LV volumes. So this is not about fluid, folks. This is about myocardial stress, and these secular trends over time are quite telling. And the reason why this is exciting is because there's now imminent development. I'm helping the company develop this, home-based testing for N-terminal proBNP as well as kidney function and potassium. It's a smartphone-based device, finger stick, 35 microliters of sample, 30 microliters of sample, strip technology. The device sits on a desk. It's just the same size as an iPhone and connects via Bluetooth and transmits the result via Bluetooth. So that, if you ask yourself, well, how are we going to, get blood tests on our patients? It's a real pain to get folks to go into the lab before we see them in the office. This gets around that issue, and it allows us to be able to monitor patients remotely and then ultimately manage them remotely. In our GDMT clinic, for example, we see people for a first visit in person, and then we titrate their GDMT virtually with the person going into Quest or one of our own labs to get their labs checked. And then we see them in person on the last visit. This will allow us to do everything at home without them having to go in. They can go to work. You can check your finger stick during grand rounds. I mean, the bottom line is it allows for a lot more flexibility of care. So what we recommend in recently decompensated patients, we get them straight into the clinic 1 to 2 weeks after discharge, and we bridge from hospital to home. We have their pre-discharge value, we get their office-based value, and then in stable outpatients, we measure about every 3 months. One of the things that we argue about is, well, what are you going to do with the result? Well, I'll tell you what we do with the result. The first is, as we're adjusting GDMT, one of the questions, and I'm sure this comes up in your heart failure practice, when do you stop loop diuretics? And how do you feel about stopping loop diuretics in somebody that you're not going to see because they live remotely? So many of our clotters, people who focus on thrombosis, will, when they stop warfarin in somebody with a history of thrombosis, will get a D-dimer and monitor and watch for a rise in D-dimer after stopping an oral anticoagulant. Same idea here. If you've got someone that you've got them on optimal GDMT and you want to stop their loop diuretic because you feel like they can fly without it, a measurement of natriuretic peptide provides useful information about the safety of stopping loop diuretics. In addition, how do you use the test? For people with stable, low, suppressed concentrations with stable symptoms, the cost effectiveness of doing routine imaging in these people is really low, right? They're stably not remodeling. And so as a consequence, these are people that we don't do yearly CPETs on, we don't do yearly right heart caths on. We may image them if they've got valve disease or other things to monitor, but if you're just looking for change in EF, not a whole lot of value from doing that. On the other hand, people with higher or rising concentrations, these are the people that you want to put all your fury of medical follow-up on. And for those with markedly elevated concentrations, those are the people you want to take a step back and ask, what am I missing? Right? And one of the things that has been really an eye-opening experience is the number of people that I've identified as having transthyretin cardiac amyloid who have marked elevations of natriuretic peptide despite all efforts to try to get these patients more stable. And so it's an important sort of little tell that there are things that stimulate natriuretic peptide release beyond the classic diagnosis of heart failure. Lastly, I'm going to finish in the next few slides. We'll circle back to other markers. And troponins, I've already hinted, are a very good marker for identifying myocardial stress. And indeed, whether we look at reduced EF or preserved EF, troponins are a very powerful predictor of adverse outcome. They are additive. In fact, in Emperor on the left, we showed in Emperor that out of 100 or so variables predictive of risk in both reduced and preserved heart failure, there were 2 variables that sat at the top of the statistical analysis with a mile between the rest of the variables in terms of their importance. It wasn't age, it wasn't duration of heart failure, it wasn't kidney function, it was NT-proBNP and high sensitivity troponin, right? So very high risk findings in folks with heart failure with preserved and reduced EF, and they're additive. And indeed, changes in troponin over time are also predictive of outcomes. So why might that be? I was talking last night about this, because when you put cardiologists together, we don't talk about baseball, we don't talk about the weather, we talk about what we do for a living. What we found is sort of interesting in a study. We measure biomarkers in clinical trials, usually same time point, we measure everything, right? So we measure NT-pro, troponin, blah, 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 and we analyze them together. But what we found, which makes complete sense, remember that cardiomyocyte shedding exosomes, was that the best predictor of troponin on a Friday, for example, was NT-proBNP on the preceding Monday. In other words, stress begets release of troponin. And so changes in troponin are identifying unmitigated myocardial stress, presumably reflected by elevated natriuretic peptide, which is why when you put them together, like in the upper left-hand corner, as we say in Boston, this is wicked bad stress here, right? It's both natriuretic peptide and troponin. This is unmitigated strain on the myocardium. So indeed, in PROVE-HF, Sean Murphy showed that the combination of larger reductions in troponin together with larger reductions in NT-proBNP were associated with the most amount of reverse cardiac remodeling. In other words, if you mitigate both, you get most improvement in heart muscle integrity. And this is an important message for those of us as we're starting to think about individualizing how we understand our patients. So lastly, I've sort of given you sort of the futuristic view of where markers might fit in. What's next? Well, by and large, what we measure in the lab, in the wet lab, in the clinical labs, is based on immunoassays, colorimetric assays, things like ELISAs. These are very primitive when you see where the technology is heading, which is the use of what we refer to as omics, right? Either metabolomics, genomics, or in my case, proteomics. And the reason why there's so much promise here is because omics can be used to identify new markers which can help us to better understand disease, and ultimately, I would argue, not only help us develop tests to identify those diseases, but to better treat them. And there are a number of different ways. Mass spec was the way we used to do it, but now by and large, we're either using aptamer-based technology or proximity extension assays, which allow you to, with just as much as 1 microliter of blood, identify literally thousands of proteins in the same sample. And together with really ultimately complicated statistical modeling, you can develop really interesting knowledge about disease that you didn't potentially know about previously. I'll give you 2 examples and then I'll finish. IGF binding protein 7, it's an insulin-like growth factor binding protein that was identified in a proteomic search of cardiac remodeling, actually. It's found actually in multiple organs. It's found in the kidneys as well as the heart. And indeed, in urine, IGF-BP7 identifies risk for acute kidney injury, actually. But what's interesting is that when you look at its biology, it's a senescence marker. So what are senescence markers? When tissue is injured, the body shuts down their function because it wants to avoid the risk for oncogenesis from damaged DNA. And so the senescence-associated secretory phenotype is a group of hormones that slow down tissue development and cause fibrosis. And IGF-BP7 is a member of that. Not going to show you Kaplan-Meier's, not going to show you tables. Take my word for it, this is a bad marker of risk. It identifies risk in a number of different disease states. But that's not really interesting, right? Who cares about prognosis? It turns out that it's actually a target for therapy. So Peter Liu from Ottawa, who's a close friend and a brilliant scientist, was the person who identified IGF-BP7, and we worked together to sort of build out all of the so what, that it's a bad, predictor of risk. But what Peter did was he actually developed knockout models as well as therapeutics to lower IGF-BP7. And what he's shown is that in models of heart failure, blocking this senescence-associated protein prevents heart failure onset. So that's now being brought forward as a potential therapeutic and would not have been identified if it weren't for proteomics as a tool to identify. Lastly, what about coronary disease? Karam, I put this in for you, right? I thought I had to do something to sort of say that we can maybe add to coronary artery calcium. So this is not heart failure, folks, but since Dr. Nazir's here, I had to do this. We took samples from patients, around 1,250 patients in our cath lab, and using advanced machine learning technology, we measured a bunch of markers and came down to predictors of obstructive coronary disease. So this is not imaging, this is circulating proteins and clinical variables. And what we're able to show is that you can get near 90% area under the curve. This was in JACC. This is not in like the ACTA retracta, with remarkable association between the level of these proteins and the degree of obstruction in the coronary arteries. And you can actually triage very quickly more than about half of these patients with very high predictive value. So it just shows how omics can really move us forwards to panels of markers that might be able to do much better than the current tools. But what's the holdup? And this is literally my last slide. The problem is that we're getting faster and faster in our ability to identify these markers, But the problem is that the technologies to translate them to patient care is moving at the speed of a snail, as I said. It takes time to develop robust assays for novel targets. The in vitro diagnostics world is struggling with slow regulatory aspects from the Food and Drug Administration. And furthermore, they can be developed as lab-developed tests, or LDTs, but there's a lot of ambiguity about the laws regarding whether LDTs will allow to continue in upcoming years. And so what we really need to now start thinking about, your medical school with a tie-in to engineering, for example, is how we can take findings from the bench or the wet lab and the translational lab and more rapidly bring them to patient care in a robust and high fidelity fashion. We talked about how these tests are support but not replacement for clinical judgment, but I hope I've sort of portrayed how we've gone from using these tests to identify acute heart failure and acute myocardial infarction to really trying to understand how we can leverage the biology they're reflecting and add to our clinical judgment to predict heart failure risk. So in conclusion, from the earliest identification of the markers we've talked about today, there's been really slow evolution towards where I think we're getting, which is an increasing focus on prevention. You know, we first focused on diagnosis, then prognosis. People sort of shrugged and said, who cares about prognosis? Well, the reason why we care about prognosis is we can now operationalize those findings and really reduce the risk. I really firmly believe that 10 years from now, when I'm no longer doing this, hopefully, God willing, we won't be just measuring NT-proBNP and troponin, and that we'll have a greater depth to the toolbox that we open when we want to evaluate and manage our patients in a more precise manner. So with that, I'll stop. Thank you very much. Clean up your desk here.
So what a wonderful lecture, thought-provoking, lot of ideas, and of course, our power of zero was really influenced. I would say from the old work where the NT-proBNP and the BNP cutoffs were shown with a 99 negative predictive value of ruling out disease. And that's kind of, I think so in this day and age, not only finding those at risk, but those who are at a lower risk are going to be critically important. And I can tell you that it's hard convincing my colleagues with a negative predictive value of 99% that the power of zero holds in symptomatic patients. Jagat and I wrote an editorial for JACC. We're still pushing on that. Two practical questions for you to start with. One is that now within prevention and in our prevention clinic, practically, of course, we want to do screen for diabetes, but should we extend beyond that? And are there any factors and how often we should be doing that? And secondly, now with the high sensitivity troponins, a practical question around the CAD bundles that's happening, and of course some of your work has shown. The issue is what would be the implications of now the type 2 and the acute non-ischemic injuries getting part of the bundle, and how can we solve that? Because that's not what I thought that the bundle was supposed to be.
Yeah, great questions. So first about prevention, I really firmly believe that, I would relish the opportunity to open a heart failure prevention clinic, for example, rather than, managing these patients once they're symptomatic. But the truth of the matter is we all have a heart failure prevention clinic, right? And so it's about trying to understand the best means to identify the highest risk patients and operationalize. In the ADA consensus document, we actually concede that, with 40% of the population having dysglycemia, is everybody going to get a troponin and NT-pro? Not really feasible, probably. But who are the people that you want to identify as being highest risk? Long duration diabetes, advanced age, CKD. Little tip, an abnormal troponin in somebody with chronic kidney disease is not a false positive. Right? That's not a false positive. That's actually a higher risk finding than an abnormal troponin in somebody with normal kidney function. So, in the ADA document, we sort of give levels of who are the highest likelihood for output from a screening program. And I don't like the word screening, to be honest. I use that term, but early detection is really a better way of putting it. So I do, actually in my own practice, evaluate for the presence of unrecognized diabetes. But, Mikhail Koziborod in St. Luke's, has a cardiometabolic practice where they operationalize this approach, where people with diabetes and stage B heart failure are treated very aggressively. People say, well, but they're probably already getting a GLP-1 receptor agonist and an SGLT2. I'm sure you've seen the data. Fewer than 20% of eligible patients are getting these life-saving drugs. So there's a great opportunity to improve the care of patients. As far as the myocardial infarction topic is concerned, that's a long discussion about improving fidelity for type 1 and type 2 MI. So type 2 MI being supply-demand inequity causing myocardial infarction. The problem with type 2 MI is that we looked at the Mass General Hospital, where we're never wrong, right? We're never wrong. And we found that of the 632 patients that had a type 2 MI code used for their diagnosis, half were incorrect. Half had a rise and fall of troponin in the setting of stress, but they didn't meet the universal definition. So to be very, very clear, when you see a rise and fall of troponin, you need to think of it almost like a natriuretic peptide. There's something stressing the myocardium. There's maybe something killing the myocardium, but it may not be an infarct, right? So, there's much that needs to be sort of worked on there.
All right, Dr. Zogby.
Jim, thank you so much for coming in. Very enlightening. Major changes, particularly now going in earlier phase of detection of risk. I have two questions for you. One, practical questions. One, the scenario that you mentioned, where despite improvement clinically, the proBNP, or NP-proBNP is increasing, and the question is why there's no cleavage of such to improve it, and how would you suspect it, in these situations? Well, and two is, from a practical point of view, obviously we follow symptoms, vital signs, and blood pressure, and how much can patients in chronic heart failure can tolerate in addition to their kidney function. How often would you repeat these biomarkers? Because obviously it may tell you something about it, but maybe not too frequently.
Yeah, thanks, Bill, for both questions. So as usual, Dr. Zogby asked some really important, practical, but actually pretty deep questions. Why do people have a rising natriuretic peptide on a biological level? One of the things that we showed, Bill, was that the cleavage of proBNP into active BNP and NT-pro was driven by an enzyme that cleaves at a site in the precursor peptide that has varying levels of glycosylation. So the more glycosylation on the peptide blocks the ability of the enzyme to cleave it. And in a normal situation, when the myocardium is stressed, the body pulls the glycosylation away and allows the enzyme to cleave. But for reasons that nobody understands, with advancing disease, it remains there and it prevents corin from activating it. So it's a really interesting, and potentially druggable, target. And so
it may give you a false sense.
Absolutely, yeah. And so there's a lot of interest in trying to develop even more accurate technologies to detect that process. The second question, how frequently? I put every 3 months in stability. That's just on the basis of guided. Once we have a scalable, low-cost, home-based approach, we've done some focus group testing, focus group questionnaires with cardiologists, and asked them, if you had a means by which to measure NT-proBNP in your heart failure patient, how frequently would you measure it? I want you all to think of the answer that you would say. And what the overwhelming number was about once every 1 to 2 weeks. Now that may be a little too frequent. Personally, I think it is. But if you have patients that are unstable or undergoing GDMT titration, it's absolutely not too frequent. I think it depends on the scenario. I have some patients that are rock solid stable. I probably wouldn't even use the device in those patients. But I have patients that are running NT-proBNPs of 600, 700. That's not normal.
I hope that I never see a 3-digit number of my NT-proBNP in my lifespan. So when you get up into the 600-700 range, that's when the myocardium is starting to remodel, and when you're above 1,000, it definitely starts to accelerate.
All right. Question?
Thanks. Great talk today. So one of the practical implications of what's happening with the obesity epidemic is we're all going to start seeing more and more patients whose BMI is much higher.
Yeah.
And so I wonder what your thoughts are in terms of the interpretation of these assays in the setting of obesity, specifically for natriuretic peptides, as you showed some of the different phenotypes with how there's different responses to cardiac remodeling, as well as what practical guidance you would give for using a multi-marker approach, particularly in that setting.
In obesity. Yeah, great questions. So obesity, literally in 10 seconds, obesity causes lower natriuretic peptide concentrations, not because of increased clearance. It suppresses the BNP gene, presumably on the basis of androgen release from adipose. This is why women have higher natriuretic peptides than men in health. And when a person is obese, they tend to have anywhere up to 30% lower natriuretic peptide concentrations compared to someone with the same severity of heart failure who do not have obesity. So it does, create some issues. What has been shown is, and it unfortunately leads to a lack of a one-size-fits-all approach. But if you have someone who has obesity and reduced EF heart failure, their secular trends in NT-proBNP hold just like somebody without obesity, but their values are lower. So you have to recalibrate what threshold values you're using in the setting of obesity. Somewhere between 10, 20, 30%, depending on the severity. However, there are other markers that are not affected by obesity. Troponin, to some extent, is because it follows the amount of myocardial stress and NT-proBNP releases that you see, but it's less so than NT-pro, which is why in the ARISE-HF study, which I'm presenting next week at ACC, to include people with stage B heart failure, we used NT-proBNP or high-sensitivity troponin, and the values that we used were lower because this was a population who had obesity generally. ST2, another marker that I didn't mention, is a marker of myocardial fibrosis, very powerful, as is IGF-BP7. Neither of them are affected by obesity. So the future may hold that we use different markers depending on the patient type.
One last question.
Thank you. Fascinating talk, and thank you for all your work in the biomarker space, that we're finally seeing the fruition of BNP as a therapeutic applications for GDMT optimization and translation. I mean, my question related to this is, when you look at the role of biomarkers, as you've shown elegantly, troponin, BNPs, we think of it as a diagnostic tool, we think of it as a prognostic tool. But when you wear a hat of an implementation science aspect, the stakeholders don't care to risk prognosticate if you don't have anything to implement.
Agreed.
So my question to you is, with proteomics, there is a plethora of discovery that's going to happen. Is it time, based on what you've learned, to create a guidance for these discoveries to actually have the implementation therapeutics in mind before you just start discovering 100 molecules?
I love that question. And as somebody that works and has worked with Jagged at Jack and now with Karam at Jack, I mean, what I will tell you is it is exhausting to be the biomarker editor at a journal, because you just get Mike Felker and I wrote an editorial entitled "The Biomarker Tsunami at Jack Heart Failure." I completely agree. There's no use in identifying some never heard of biomarker and showing that it has a hazard ratio of 1.2 for events. That's a meaningless observation. And so, a firmer stand needs to be taken about what exactly constitutes a meaningful observation and how it can be brought to the next level. The reason why oncology is blowing our doors off with personalized medicine is because they can get a piece of a tumor and analyze it in that way. But to some extent, we have to get to that state where we have a means by which we can identify a biological process and then go to the lab and develop a therapy. Omecamtiv mecarbil is a drug that, as you probably know, was developed in a very directed way. The cardiac myosin inhibitors are another example, two sides of the same coin in a sense for therapeutics, but that kind of approach, I think, is, to use markers to identify potential targets that can then be drugged is absolutely the future as far as I'm concerned.
Perfect.
Thank you.
James, thank you so much. Wonderful.
Appreciate it.